Fear. Right now, there is a lot of fear because of COVID-19. People are scared of leaving their homes, scared of shaking hands with humans, and scared of going to hospitals because that is where COVID-19 patients go. So even if we need to see a doctor, we stay at home, and sometimes waiting could make things worse.
When news of COVID-19 spread, people stop coming to the hospitals. Even if they are not infected by the virus, they become infected by fear.
But did you know that hospitals may be the safest place in the world right now? When they started admitting COVID-19 patients, they had isolation rooms and special wards for these patients. One ward for COVID-19 patients, separated from the rest of the hospital, leaving the rest of the hospital safe for everyone else. So every time a COVID-19 patient walks in, they get dedicated nurses to take care and support them.
Safety is our number one priority all the time. This helps to keep not just our staff, but also our patients and the general public safe.
They have doctors that specialize in infectious diseases, separate security 24/7, separate disposable cutlery, and even separate air ventilation systems to make sure even air doesn't go to other parts of the hospital. This separation is vital to keep everyone safe because for all other patients, it's the new norm. Many people still need hospitals, especially when they have worrying symptoms like chest pain, vomiting, or sharp pain in the stomach that need urgent medical attention.
Because of our very strict protocols and safety measures, our hospitals are safe, and that is a fact.
Because everyone, from senior management to doctors to nurses to security guards to chefs, is doing the impossible to keep the hospitals safe for you. So, only if you need urgent medical treatment, stay home, be safe, and keep healthy. Health insurance is complicated, so let us simplify it for you. This is a plate of delicious fried rice. It's like the basic health insurance that we all enjoy. It can protect you when you fall ill and get hospitalized, and helps you save money. But what if you had the choice to upsize it? Add this, and this to your meal. All of a sudden, your meal has more flavors. With private health insurance, you can enjoy more options. Your hospitalization and surgery are covered. You can choose your own doctor and see them in 48 hours. You just need to focus on recovering and leave the rest to them. Healthcare isn't supposed to be confusing. It's supposed to help you.
A good day to all of you and a warm welcome to Mount Elizabeth Hospital Annual Medical Seminar 2020. My name is Charlene, your host for today. This event is jointly organized by Mount Elizabeth Hospital and Mount Elizabeth Novena Hospital. This virtual event is conducted via 4 lunchtime webinars and featuring over 9 medical experts. They will be touching on the topics on the new norm to bring healthcare forward. Now, for those of you who are tuning in right now, GPs, specialists, and medical professionals, a warm welcome. If you have missed out on the earlier sessions, you can also log in via our event website. For those of you who have registered using the MCR number, you are also eligible for the CME points. And right now we're presenting live from the Medical Presidential Suite in Mount Elizabeth Novena Hospital. Let us dive right in to take a look at our doctors and their presentation topic today. Today we have Dr. Tan Po Singh, the gastroenterologist. His topic will be approach to abnormal liver function tests and chronic liver disease in primary care. We also have with us Dr. Lai Xiang Hui, President, Medical Legal Society of Singapore. The topic will be Bolam, Bolitho, Montgomery and beyond. We will also have a Q&A session that will be moderated by Dr. Fu Chek Xiang, General Surgeon. And also before we start, there are some reminders for us to keep in mind. For the Q&A, on the bottom right of your screen, there is a Q&A button that can be clicked on to call out the Q&A sidebar. So click on it and put in your questions. So once your question is approved, it will appear under the live questions list. You may close the Q&A overlay once you are done and call it out again if you have new questions. This webinar is also accessible via our Mount Elizabeth Hospital's YouTube channel. A gentle reminder for doctors to log in via the event website for your CME points. For our viewers on the YouTube channel, you can also put in your questions via the comment box. So if you're posting on the social media, do tag us and the hashtag is MEAMS2020. So if you encounter any technical difficulties, please contact us. Our crew are on standby to assist you. At the end of the session, please help us by filling out the feedback form. Your suggestions and feedback will help us to improve our future events. Last but not least, we'd like to thank our sponsors for the event. Platinum sponsors, Teleflex and Pfizer. Gold sponsor, Sandoz. And silver sponsor, Boehringer Ingelheim. So without further ado, let us now welcome our first doctor for the day, Dr. Tan Po Singh. He's a gastroenterologist practicing in Mount Elizabeth Hospital with extensive clinical expertise in the digestive diseases, endoscopic procedures, liver diseases, and liver transplantation. So let us welcome Dr. Tan, please.
Hi, thank you, Charlene, for the kind introduction, and good afternoon to all my friends and colleagues. I hope to meet all of you next year in person. Today, my topic is approach to abnormal liver function tests and chronic liver disease in primary care. So let me share some of the key facts about our liver with you. It is the largest internal organ and it has the amazing ability to regenerate. But despite this, chronic injury and inflammation can lead to fibrosis and eventually cirrhosis. But fortunately, this process is usually reversible even in patients with early-stage cirrhosis. Now, I think it's probably very common to pick up abnormal liver tests in your practice, and I do see referrals for patients with abnormal liver function tests quite often in my practice. So that's why today I've chosen to talk to you about this topic. Finally, I would like to highlight to you that liver transplantation is a life-saving procedure that can be done to save patients who are suffering from end-stage liver disease. Living donation is possible, and even patients with selected liver cancer can receive liver transplantation. But perhaps we'll leave this topic for the next talk if we have the opportunity. First up, I would like to talk to you about liver blood panel, or you can call them liver blood tests. And in the olden days, we call them liver function tests. Now, in the context of liver disease, I think it's good to go through some of the components that we have in the liver test panel. First up, we have albumin, bilirubin, and INR. And these three components really represent the liver function of the test that we do for our patients. They represent the synthetic and excretory function of our liver. So if a liver has suffered significant damage, or patient has liver failure, these markers will often be abnormal. Second up, we have the hepatobiliary enzymes, which are your ALP, ALT, and AST. So these are enzymes that are leaked out from the hepatocytes when they are under stress or injured by various etiologies. And these are the ones that you often detect when patients do their liver panel review and if they have a liver disease. Finally, when I look at the liver blood test, I also look at the platelets, which some of you may not be attuned to look at it most of the time when you see a patient with liver disease. But to me, it's particularly important because it will tell me whether a patient has significant liver damage or if they already have significant portal hypertension. So the platelet will often be low in these circumstances. First up, I would like to talk to you about alkaline phosphatase, or ALP in short. It's produced mainly in the liver, but it is also found in bone, intestine, kidneys, placenta, and white blood cells. Now, the causes of ALP elevation, we can divide it into hepatic causes, which will usually be your cholestatic liver diseases or biliary obstruction. So for some of the cholestatic liver diseases that I usually encounter and treat would include things like primary biliary cholangitis, primary sclerosing cholangitis, cholestasis due to sepsis, or even medications. Now, biliary obstructions is usually very obvious, but because patient would present with pain, and often they might be jaundice, and the imaging would show this up. Whereas for rest of the biliary disease, cholestatic liver diseases, imaging may be normal, and often very specialized tests can only diagnose this condition. Secondly, patients with heart failure, especially if they have a severe right heart failure, it may cause hepatic congestion, and this can often result in elevation in the alkaline phosphatase and even the bilirubin. So in a patient with the right context, isolated ALP may represent hepatic congestion. Thirdly, there will be non-hepatic causes, for example, diseases of the bone, such as vitamin deficiency, osteomalacia, or renal bone disease. So if a patient tells you they have bone pains and the rest of the liver function test is normal, and it's just the ALP is elevated, you have to consider the possibility of a bone disease causing these enzymes to go up. Now, GGT can be very useful to help you to differentiate whether the ALP elevation is due to the liver or not. Now, GGT is found in the liver, but not in bone. So if a patient has elevated ALP, but the GGT is normal, then it's highly unlikely that the ALP elevation is due to the liver. You really have to look for non-hepatic causes of ALP elevation. Now, common causes of GGT elevation, especially in isolation, will be patients who drink alcohol in excessive amount, or if they are taking certain medication that induce this enzyme. And nowadays, fatty liver disease, or NAFLD, is also a common cause of isolated GGT elevation. Next up, let's talk about the aminotransferases, which are your AST and ALT. These are mainly found in your hepatocytes, with the ALT being a more liver-specific enzyme. AST are also found in muscles, kidney, and brain. So in patients with myositis from virus infection or acute myocardial infarct, the AST will be elevated, but not so much of the ALT. Now, in patients with liver disease, you often find that the AST and the ALT are both elevated, and this can be due to viral hepatitis, including the common hepatitis A, B, C that we see, or even other infectious illnesses such as dengue or COVID nowadays. Fatty liver disease is getting very common around the world. It's estimated that up to 25% of people may have NAFLD, and a subset of this would have elevated AST and ALT to indicate steatohepatitis. Alcoholic hepatitis, drug-induced liver injury, autoimmune hepatitis, Wilson disease can also result in hepatitis that manifests in terms of AST-ALT elevation. Biliary obstruction can also result in AST-ALT elevation. While it might be counterintuitive, but When the bile duct is severely obstructed, the high pressure sometimes causes stress to the hepatocytes and results in the AST and ALT being elevated significantly over a short period of time. So when should you really order liver blood tests in your practice? I think we commonly run the liver panel test in the health screening package. But I will also urge that for those of you who see your symptoms with very non-specific symptoms such as fatigue, nausea, or loss of appetite, check their liver panel test because liver disease can result in these non-specific symptoms. Patients with strong family history of liver disease, you should consider screening them for hepatitis B and also screen their liver function test. And obviously, if patients already have symptoms and signs of chronic liver disease, you will need to check the liver panel. There's an argument to be made to look for non-alcoholic fatty liver disease in at-risk patients, and this will be the patients with metabolic syndrome and diabetes. But this is still controversial. We do not have a very good algorithm in terms of how to actually screen for this patient and what to do with them. So it's just something for you to consider. So what can you do if a liver blood test is abnormal? You can either watch and repeat or go straight and evaluate now. I will go more for straight away evaluation now because studies have shown that most of these patients, if you just adopt a watch and wait strategy, majority of them would still have abnormal tests after a month. So you can save patient a visit by doing upfront investigation once you detect the liver function test is abnormal. If the full blood count and INR has not been done, I will consider adding these two items in, looking at the platelet. INR, obviously, if there are already signs of decompensated liver disease. I think it's important to screen for viral hepatitis A, B, and C because these are not rare in our community, and also an ultrasound of the liver. Now, the Doppler study of the hepatic vessels is probably optional at the primary care setting, but when patient sees me, this is often one of the tests that I will order to make sure that they do not have things like what we call portal vein thrombosis or hepatic outflow obstruction. Now again, for patients that have been referred to me, if the viral hep A, B, and C are negative, I would screen them for causes such as autoimmune hepatitis with anti-nuclear antibody, anti-smooth muscle antibody, immunoglobulin G, and to look for primary biliary cholangitis with anti-mitochondrial antibody. Ceruloplasmin will be a screening test for Wilson disease. So when should you refer to a liver specialist? I think this provides a guide to some of you. Now, I think patients should be referred immediately to the A&E or to see a specialist immediately on the same day if they have signs of liver failure, such as presence of hepatic encephalopathy, or if the hepatitis has resulted in jaundice. Because when jaundice has occurred in the setting of a hepatitis, it represents a very severe form of hepatitis, and patients are at risk of going into full-blown liver failure. So I think it's important to get seen and managed early. And obviously, if the liver enzymes are more than 10 times the upper limit of normal, or if they have signs of infection that require prompt antibiotic treatment, they should be seen immediately within the same day. You can refer them early if you suspect patients have cirrhosis, or if the imaging suggests there might be a presence of a liver malignancy, or if their liver enzymes are 3 to 5 times the upper limit of normal. So we have a bit of time to organize a referral here. For the rest of the patient, I think it's all right to do the workup and then to see what is if you can determine any etiology before you decide if you want to refer this patient to a liver specialist. So let's use a case to illustrate this. This is an interesting patient that I have been treating for the past few years. 54-year-old lady. She was on simvastatin for high cholesterol for a few years. She takes TCM once a while, which is not rare in our society, to boost her health. That's what she told me. She has been having jaundice symptoms for about a week. And as you can see on the blood test, the bilirubin is elevated. AST, ALT are both significantly elevated. So is the alkaline phosphatase. Her platelet is a little bit on the low side. And the viral screen for ABC are all negative. Ultrasound only showed mild fatty liver. So obviously this case was referred to me for further evaluation. Now when I saw her, my differential diagnosis at that point in time included drug-induced liver injury because of the use of the TCM, autoimmune hepatitis, and primary biliary cholangitis, because these autoimmune diseases are common in women. So the blood test that I sent off to screen for this condition came back as positive for autoimmune hepatitis. And she underwent a liver biopsy, which further confirms this diagnosis. And my diagnosis for her was severe autoimmune hepatitis. Severe because of the presence of jaundice. She was promptly started on prednisolone, 60 milligram, and very rapidly her liver function test improved over the next few weeks. And currently she's stable on low-dose prednisolone as well as azathioprine. Now, the second part of my talk is about chronic liver disease in primary care. Now, I think of all the liver diseases, chronic hepatitis B and fatty liver disease are two conditions that are very well suited to be managed at the primary care level. For other conditions, they often would require specialist investigation and management. Now, hepatitis B and fatty liver disease, we probably have about 200,000-300,000 of them in Singapore, so there are a lot of them. And for hepatitis B patient, the one that are suitable for management in primary care would include those with normal liver enzymes, no evidence of fibrosis or cirrhosis, the young ones with no family history of liver cancer, and not taking any immunosuppressants. Now, why I included not taking immunosuppressants is because steroids or other forms of immunosuppressants such as azathioprine can result in a hepatitis B flare. So this should be closely followed up and managed in a specialist setting. For the patients who has inactive hepatitis B, they should be monitored every 6 months with ultrasound liver, alpha-fetoprotein as part of the HCC surveillance, and also their liver blood test panel every 6 months. And we should determine their fibrosis risk every 2 years. I'll come on to this in the next slide. Now, fatty liver is again another very common condition that I think all of you seen in your practice. The patient that can be managed in your setting will be those with normal liver enzymes with no evidence of fibrosis and cirrhosis. They should get their full blood count and liver blood test done every 3 to 6 months, and also have their fibrosis risk determined every 2 years. So how do we evaluate for advanced fibrosis in the primary care setting? I think when patients have symptoms and signs of cirrhosis, it's very easy, but a large proportion of patients would have advanced fibrosis or cirrhosis subclinically, meaning that we need blood tests or specialized investigation to detect this. The blood tests we can use would include your albumin level, which usually is low in patients with advanced fibrosis. And also, if you notice that the AST to the ALT ratio is reversed, meaning that AST is higher than the ALT, because a normal AST to ALT ratio should be less than 0.8. And also, thrombocytopenia points to the presence of advanced fibrosis and portal hypertension. There are more fanciful biomarkers that we can use in our practice. Now, some of these include what we call the APRI score, FIB-4 score, NAFLD fibrosis score, and also more specialized proprietary tests such as HEPA score, FibroTest, and ERF score. Some of you might be familiar with this, but for those of you who have not heard of this, these tools actually can be found online. There are free calculators that you can use to help you to determine whether patient has significant fibrosis or not. For the patients that come to see me, I will often perform a transient elastography, either in the form of ultrasound-based fibroscan or MR elastography. They represent a good way to determine fibrosis and has been validated in many conditions. Finally, the good old liver biopsy, still considered the gold standard, but it comes with its own set of risks of bleeding as well as sampling error. Now, for those of you who are familiar with biomarker tests or who are deciding that you will use this after today's talk, I just want to point out to you that you need to be aware that which test has been validated in which disease and use them appropriately. For example, the top 3 that I shown here, the APRI, FIB-4, and NAFLD fibrosis score, have been validated in fatty liver disease but not in hepatitis B. Whereas the proprietary test has been validated, but you have to pay for this and they are not so easily available. So to me, I think the free test is still good. So good and cheap. And FibroScan, as you can see in the bottom table, has been well validated in many diseases with high accuracy and reliability. And it's non-invasive, hence the reason why I use it quite often in my practice. This represents a simple algorithm that I thought would be useful to guide you how to assess your patients with liver fibrosis in your practice and to decide whether they should be referred to the specialist. So what you do in the setting of Hep B and NAFLD, for Hep B, you can use the clinical markers such as albumin, AST, ALT ratio, and platelet. For NAFLD, use the online NAFLD fibrosis score. If these markers suggest to you that patient has low risk, just manage them in your practice, do the test every 3 to 6 months, and repeat this evaluation in 2 years' time. For the patient that has signs based on these tests that they may have advanced fibrosis, please refer them to your friendly gastroenterologist. We will likely do a fibroscan, if not a liver biopsy, to determine if they have advanced fibrosis. So just a final case to share with you how we can utilize this. A man that is seeing you for diabetes, mildly abnormal liver enzymes, platelet is still normal, fatty liver on ultrasound. If you Google NAFLD fibrosis score, this is what you get. You input all the numbers. At the bottom, you will see it will give you a score, 0.72, and it will tell you that this correlates with a fibrosis severity of F3 to 4. F3 to 4 represents advanced fibrosis. F0 to 1 is normal or very mild fibrosis. So the patient with F3 to 4, you should refer them to us. When I done the fibroscan for this patient, confirms that he has F3 to 4 advanced fibrosis. I need to apologize that I cut and paste the report a little bit wrongly. So if you see the CAP score shown on the screen, this CAP score is a measurement of fatty liver. It's actually much lower than what I expect in the patient with fatty liver. This is not his actual report. For patient with fatty liver, we often expect the CAP score to be more than 300. So my apology for including the wrong cut and paste result for this case. So finally, my take-home messages. There are many causes of abnormal liver tests, but the most common one would include fatty liver, viral Hep B, alcohol, and including drug-induced liver injury. I remind you to include liver blood tests for your patient with non-specific symptoms, not just those with jaundice or right upper quadrant pain, because hepatitis can present quite non-specifically. Do remember that with patients who have hepatitis and jaundice, it's a bad sign. You need to refer them early or even urgently to either the A&E or a hepatologist. And for the hepatitis B patient and fatty liver disease patient that you are following up, please remember to determine their fibrosis score. For Hep B, you can use things like albumin, AST-ALT ratio, and platelet count. And for the fatty liver patients, just Google NAFLD fibrosis score and use the online calculator. With that, I thank you very much for your kind attention.
Thank you so much, Dr. Tan, for the great sharing. Next, we'll have Dr. Lai Xianghui. He's the president of the Medical Legal Society of Singapore and currently serves as a faculty and board director on the CMEP of the Singapore Medical Association and is trained in general and forensic pathology. He spends a lot of time on undergraduate and postgraduate pathology education, teaching and advising on issues relating to medical legal, professional, and also ethical practice of the medicine. So let us now welcome Dr. Lai, please.
Good afternoon, and thank you for inviting me to give this talk. I speak as the president of the Medical Legal Society, and from the title of the talk, I think you understand that it's probably related to medical negligence and civil medical litigation. I will be talking about some basic concepts about civil medical litigation and then bringing into context in the cases in Singapore as well. For the basic concepts, I'll be highlighting these three cases, the Bolam case as well as the Bolito and the Montgomery case. The case of Bolam, which gives rise to what we commonly know as a Bolam test, is happened in 1957, quite a long time ago. And this gave rise to the case. This was a mental patient that had electroconvulsive therapy. Unfortunately, there was no muscle relaxant given, and the patient suffered multiple fractures. So he sued the hospital. The case was ruled in favor of the doctors because it was stated that a doctor is not guilty of any malpractice if there's a responsible body of medical men skilled in the practice and agrees with the opinion, so to speak. And because of that, this became the Bolam test, and most of the time we know it as the basic test of medical negligence. But that made it a little bit difficult for patients to so-called win cases against doctors because it was always easy to find a body of medical opinion that agrees with the practice. Therefore, we have this thing called the Bolito qualification or Bolito modification of the Bolam test. And sometimes we just call it Bolam-Bolito concept or test. So in this case of Bolito in 1997, so that's 40 years after the initial case of Bolam, this involved a 2-year-old patient that was admitted for respiratory distress. The doctor who was responsible unfortunately did not attend to the case twice upon a request by the nurses. Eventually there was brain damage and the patient actually did quite badly. Understood, I think the patient actually died. But so the case was brought against the doctor. And the doctor's defense was that nothing would have changed even if she had seen the patient, because the patient might not actually have been intubated because of all the inherent risk and other factors taken into consideration. Because of that, the case was actually ruled in favor of the doctor. In other words, the doctor was not found negligent. And so there was a problem. The case failed because of causation, not being able to prove causation. So just a reminder of what medical negligence concept is. First of all, there must be a duty of care established between the doctor and the patient. The second factor is that there must be a breach of this duty of care or violation of this duty. The third factor would be damages. The breach of this duty of care resulted in damages. And then lastly, there must be causation. In other words, it was the doctor's actions or inaction that led to the damage directly. So in this particular case, the doctor won the case, so to speak, because it was not established that the doctor who did not attend the case resulted or caused the final damage to the patient. The patient basically had risk factors and the disease, underlying disease, caused the damage. Therefore, the case was ruled in favor of the doctor. However, in the judgment, the judge actually made a statement to say that there must be sound medical practice in whatever the doctor makes a defense, that the opinion cannot just be based on a body of medical experts who agrees with the doctor. It must be based on sound judgment. And therefore, this little addition became the modification of the Bolam test, recalling that the Bolam test had a very relatively low standard for doctors to, well, sort of like get away, so to speak, just because there was another team of doctors or even a small minority of colleagues who agreed with the practice. So we see here that there was a move away from the reasonable doctor to the reasonable patient in these cases of medical negligence. The next few cases are small cases that just to illustrate how this situation evolved. So this was a long ago case, 1972, where this and the next case was actually spinal operations where there were complications following operation. So paralysis followed, and in this case, the judge actually ruled that consent must be informed to the patient. In a way, the judge actually also ruled that there must be a right of self-determination by the patient. In other words, the patient needs to be informed, and so these two cases highlighted the importance of consent. And it's not for the doctor to override the patient decision. And a risk, any material risk need to be informed to the patient who's a reasonable, if he's a reasonable patient, right? He needs to be informed, therefore, so that he can make the correct decision to whether to proceed for surgery or not. And this test of materiality, whether something is material or not, is highlighted in Rogers and Whittaker in 1992, where basically speaking is that a risk is material if the reasonable patient attach significance to it. In this context, if the patient thinks that this is important, it is significant and it's material. Of course, it will say that depends on whether the doctor can assess that this is important or not in order to inform the patient. However, let's move on. In Chester and in 2004, so this was another spinal op case, and the risk of paralysis happened. And the patient claimed that if she had been warned of the risk, she wouldn't have gone for an operation. And the judge actually agreed to say that in modern practice, paternalism no longer rules. Whatever risk, however small but well established, must be informed to the patient. So I think so there was a general move from medical paternalism to patient autonomy. Now let's deal with the Montgomery case in more detail. So Montgomery case really was the main turning point that really got doctors really afraid. What happened was in 2015, so this case was ruled in 2015, but it started of course a few years earlier, more than 20 years ago. Now the mother was a diabetic mother, small size, and she carried a big baby. The obstetrician chose not to give a risk or offer a cesarean section for delivery. So the obstetrician actually recommended a trial of labor and actually proceeded with it without informing the patient the option of doing a cesarean. So she basically, the obstetrician basically promoted trial of labor. And then as we now know, shoulder dystocia resulted and the baby became severely brain damaged. So obviously the mother brought a case against the doctor, the obstetrician. Just to let you know, this case was initially ruled in favor of the obstetrician. At the first appeal, it was still ruled in favor of the obstetrician because the expert opinion agreed that it was better, it was all right to proceed with trial of labor than to offer the option of cesarean delivery. It was only upon the highest appeal, so the patient continued to appeal, and eventually in the highest court, so to speak, the judge actually overturned the initial judgments and ruled in favor of the patient. And in his judgment, the judge said that the disclosure of information to a patient should be regarded as an aspect of medical care, and that the extent to which disclosure is appropriate should therefore be treated as a matter of clinical judgment. And that's where the problem arises. What is clinical judgment and how much should we review or offer or explain to the patient? Need it be 100% comprehensive, or what is material? So it brings into all the accumulated concepts about test of materiality, patient autonomy, right of self-determination, the concept of informed consent itself. And in that judgment, they referred to, this was a case in UK, of course, so they referred to good medical practice, which was part of the guidelines of the General Medical Council of UK. And basically, it's just, I won't belabor this, I won't read it in detail, but it basically says that patient autonomy, informed consent is important. And there you go, it says consent, patients and doctors making decisions together. And all the risks and benefits must be explained, and eventually the last line there you see, patient decides whether to accept any of the options or not. Now let's come to Singapore then. How has it impacted our practice here in Singapore? I'll just talk a little bit about what is the available guidelines, and then I'll highlight the modified Montgomery test. So the available guidelines, as far as we know, is in this thing called the Singapore Medical Council Ethical Codes and Ethical Guidelines. And to remarkably that this actually predates the Hitchcock case, which I'm going to deal with in a while. In this book, there are many sections and paragraphs written on information to be given to patients, need to inform the patients of tests and risk and so on and so forth, and the scope of consent given to patients needs to be clearly understood. In other words, it has to be explained to the patients. And therefore, what has happened? This case, Hitchcock versus the surgeon as well as the hospital. In this case, the patient actually was found to have a lesion in the pancreas of uncertain significance. I mean, they didn't know whether it was cancer or not. There was a possibility of cancer. And after a lot of discussions, the patient decided that he will opt for surgery. And of course, this was a very significant and complicated operation called the Whipple's procedure. And eventually, to cut a long story short, the lesion was found to be benign. It was non-cancerous. Unfortunately, the patient developed some complications. And because of that, he brought the case against the surgeon and the doctors and the hospital. And the courts actually ruled in favor of the doctor and the hospital. Not once, twice, but like 3 times. The patient basically brought cases, appealed and appealed and appealed, bringing more and more challenges to the management and to how he was advised to have operation and so on and so forth. Then you can see he actually lost the case even after appeal. And in the Court of Appeal judgment, the case was ruled in favor of the doctor because of 2 main reasons or factors. There was good communication that was well documented. And this actually sealed the case for the doctor. What have we learned from this? In this particular case, of course, it's now called the Hitchcock test or the modified Montgomery test. I'm going to spend a bit more time to explain this. In the High Court appeal judgment, so it was the Chief Justice himself with another panel of judges that made this judgment an assessment and made this recommendation. The modified Montgomery approach is like that. In the patient encounter, there are 3 elements: the diagnostic part, the treatment part, as well as the part about giving advice. As far as diagnosis and treatment is concerned, we'll still adhere to the Bolam-Bolito concept. If there is a reasonable body of practitioners with clinical sound judgment, logical judgment, makes the same decision, then that's the test of the reliability. However, in the advice portion, where there is a lot of uncertainty because every patient is different and every situation may be different. That's where the advice portion, giving options to patients and all that, it requires a little bit more analysis. So the court came out with this approach called a modified, this is why it's called a modified Montgomery test. And it's divided into 3 stages. So if you look at the chart, there's a Montgomery test stage 1. And basically this is where the patient is now given the responsibility to prove that he or she was informed of certain things. Now, was he or she given some information that he thought was material? Was relevant and material information withheld and not communicated? The burden of proof is on the patient. If the patient can prove in court that the doctor has withheld information in offering treatment guidelines. So recall the case of Montgomery, where the obstetrician actually withheld the option of cesarean delivery. So that was actually withheld. So in that case, the patient has bypassed or won stage 1. Only then you move on to stage 2. So assuming that the patient has won the case that there is material information that was withheld. So stage 2 is, was the information even available to the doctor in the first place? If the doctor had no such information or was not in possession of the information, then the test stops. There's no further, you don't proceed anymore. However, if you can prove that the doctor actually had the information and withheld the information from the patient, then you move on to the third one, the third stage, which says that, was the doctor justified in withholding information? I will not do this, this is just words explaining what I've just said, all right? So the 3 stages of medical encounter and the diagnosis and treatment is still Bolam and Bolito. Stage 1, patient has to prove that he was not given information. Stage 2, doctor had the information but withheld it. But stage 3 is important. Now stage 3 is, if the doctor had the information and withheld it, why? Was he justified in doing so? There are 3 situations where a doctor is able to defend himself by saying that I had the information but I did not give it to the patient for 3 reasons, 1 of 3 reasons. Number 1 is waiver. The patient told me he didn't want to know anything. I make the decision for him. And if you document this well, yes, that's one of the defense. Second situation is emergency situations. It's life-saving. I have no time to explain. The patient is not in a good state for me to explain the options. I have to do something to save life. So that's a second situation where you do not need to offer and explain and advise patients. Number 3 is therapeutic privilege. Therapeutic privilege is a concept where it says that if the doctor had informed the patient would have been so scared that he would have chosen not to do the treatment or be cured or be treated. So a doctor takes that therapeutic privilege to say that I choose not to inform the patient because for his own good. Now, just a word on that. It's not a good defense to mount. It's very hard to prove, right? But anyway, the court laid out these foundations for what it means for the modified Montgomery test. And then what has happened, the impact of it is that now we know that there's this thing about a reasonable patient. And there are things like material risks. And this has led to what we hear of defensive medicine practice. So we try to become more defensive in our practice. And then of course the recent cases last year, the SMC versus Lim Lian An and SMC versus Su Chuan Chang, highlighted this created a lot of commotion and activity in Singapore in our local scene. A lot of petition and so on, and then leading to the setup of a work group to review the consent-taking process as well as SMC proceedings. We await the recommendations of the work group has been adopted, but they are slowly being implemented. I mean, we're still quite new in understanding what are all the impacts, but it has got about 10 main points and in 4 categories, talking about revision of SMC disciplinary proceedings and how civil medical litigation will go forward. However, just a parting note to say that I think it's the medical landscape or the landscape of medical practice and medical litigation is getting more and more complicated. What I have to say is just that I hope that this few lines or few gems here hopefully will help you in some way. Know your patient, know your trade, and know yourself. Spend time, and yes, I think it's important, spend time, know your patient, know his concerns or her concerns, what is the material, what is significant to him or her, and then know your limits, know your trade, that means stay updated about your specialty, and know the limits of your practice. And then of course, maybe lastly, just an appeal, keep abreast of medical legal developments, and you can learn that from SMA, from the CMAP, as well as from the Medical Legal Society. Thank you very much.
Thank you, Dr. Lai, for touching on the topics that's close to the hearts of many who's watching this live. Right next, we're going to have the question and answer panel discussion. And in order to partake in a Q&A, here's a gentle reminder for you. On the bottom right of the screen, there is a Q&A button. Please call out this tab to key in your questions. Next, to make an appointment with Mount Elizabeth specialist for referrals for your patients to see Mount Elizabeth Hospital and Mount Elizabeth Novena Hospital specialists within a day, please use the hotline or WhatsApp. Finally, this event will not be possible without our sponsors. Silver sponsor, Beringer Ingraham. Gold sponsor, Sandoz. Platinum sponsors, Teleflex and Pfizer. And now our doctors, Dr. Tan and Dr. Lai, are ready for the panel discussion. And also this panel discussion is moderated by Dr. Fu Chak Siang from Mount Elizabeth Novena Hospital. So right now, I'd like to hand it over to Dr. Fu. Dr. Fu, please.
Thank you, Charlene, for hosting the session. And thank you, Po Seng and Xiang Hui, for sharing with us on this Wednesday afternoon on the two things, the two L's, which I will call on LFTs, liver function tests, and also litigation. So we do have a couple of questions here, which have been brought out to the panels. At this moment, I've got 3 questions for Dr. Tan. Now, the first question which we have here I'm not sure whether we can see it online, but the first question which we have for Dr. Tan Po Seng regarding liver function tests is, should vitamin E be given to fatty liver disease patients?
Thank you, Chek Siang. That's a very good question. Some of you might be aware that treatment for fatty liver disease includes vitamin E. Now, vitamin E is a recommended treatment for fatty liver disease patient, but non-diabetic and who has really a biopsy to prove that indeed this is just NASH, and also other workup to make sure that there are no other liver diseases. Now, you might think that vitamin E is quite benign, patient can buy it off the shelf, but when we use vitamin E to treat fatty liver, we use a high dosage, okay? And there have been various studies that shown that there is some association with regards to high dose vitamin E, as well as the risk of prostate cancer in men, and also all-cause mortality across the board. Of course, there would be confounders in all these studies. It's not a cause and effect study. It's purely an observation. So I wouldn't be using it freely for all patients. The first-line treatment for patients with fatty liver is still lifestyle measurements to lose weight, which is the most effective, far more effective than the pharmacological treatment that we have. And if they can lose weight via lifestyle, exercise, dieting, I would not need to use vitamin E for them. Yeah, that's a good question.
Thank you, Po Seng. So I've got a further question regarding vitamin E. How does this compare to, say, like Hepavite or one of those off-the-counter kind of liver tonics which is widely available and which some gastroenterologists do give? How does it differ in that sense? So would the restriction of vitamin E be the same as those given this liver tonics?
So I think all of you are aware that the Hepavites, Silymarin, and Heptral, these different variants out in the market. Again, you can buy it off the shelf. Now, the level of clinical evidence is obviously not as good as vitamin E, which is done in a randomized controlled trial manner. So we have good level 1, level 2 evidence for vitamin E in the correct subset. For some of these liver supplements, there are some studies, perhaps at level 3 or 4 evidence, case control studies, case series. The thing about them is they do work in some patients, all right? And they are fairly harmless. They do not seem to cause any major side effects, and they are available in the pharmacy. So some of my patients do use some of these liver supplements. Now, the one that has a little bit more evidence will probably the SAMe group. In Singapore, the brand name is Heptral. There are other brands that carry this as well. Now, for this to work, patients often have to also need to adopt the lifestyle measurement, not just with the supplements. So I would say they have to go hand in hand. Yeah.
Okay, thank you, Po Seng. Now, I've got other questions basically pertaining to the management of liver disease in primary care setting. And one of them, one of the two questions, the first one is, when can chronic liver disease patients be managed in primary care setting? I suppose that this is also a little bit related to the other question, which is how should fatty liver disease patients be managed in the GP setting? So I think the general trend of these questions is, as at the primary level, as a GP, when a GP encounters abnormal liver tests, I know you shared that you recommend that all these be investigated, but in practical settings, some patients having a couple of digits off the upper limit of AST and ALTs, they ask, hey, really, do I really need investigations? Can we just repeat this? Yeah, what will be your approach be? Is there basically a threshold of abnormal liver enzymes before which triggers off further investigation?
Good questions.
Yeah.
So I think it's very common. In fact, there are studies that shown that perhaps 20-30% of patients out in the community would have some form of abnormal liver function test. Obviously, you're not going to refer all of them. And the magnitude I would put as to the threshold to referral would be if the liver function test is 3 times upper limit of normal, right? And obviously, if you decide to wait a bit, you repeat in 1-2 weeks time, and if it still doesn't come down, I think perhaps should refer or get more detailed evaluation done by one of us. But if it's less than 3 times upper limit of normal, patients do not have any signs of liver decompensation, by all means, get an ultrasound. Fatty liver is probably the most likely cause. Take a good medication history, including TCM. If they are taking some medication that are known to cause abnormal liver function test, I will often tell them to hold off for some time, repeat, and then see what happens to it. Screen for viral Hep B and C in particular. A is self-limiting, so I think it's good to check, but not that critical. But B and C, I think you should screen for them. And if patients do not have them, ultrasound show fatty liver, enzymes levels are quite low, I think you can pretty much make a diagnosis of fatty liver in that case if the enzymes are not high. And get them to lose weight, do exercise, so on and so forth. If the enzyme improve, you have the diagnosis, you can continue managing them, provided that you have done the fibrosis assessments we had talked about before. But if, let's say, the patient has exercised, lost weight, but enzymes still do not come down, then it may not be fatty liver. We may be dealing with some of the rarer liver disease like autoimmune hepatitis or other things. Then that patient, even with low level of hepatitis, should be referred to specialists for further evaluation.
All right. So thanks, Po Seng. I think that's really, very helpful. But when it comes to drugs, I think one of the most common drugs which comes in private practice are statins, right? So statins are so common, obesity is so common, and liver function tests are so common. So at what level would you say that you should stop your statins? At what level of LFT derangements should you actually stop your statins?
Yeah. Again, another great question. So again, I think 3 times upper limit of normal is often the threshold. If it's above that, I think for sure should hold off the statin if has been recently started, and you can put the timeline to the statin being a possible culprit of that. But if it's just mildly elevated, sometimes it's just a matter of time before patients actually I would say adapt or adjust to the statin, and the liver enzymes will often become normal with time. So the low level, just slightly above abnormal range, I think you can observe. But also, again, patients with high cholesterol often are the at-risk group of fatty liver disease. So I think it's good before you start testing, have a baseline LFT. You already know whether they have abnormal LFT to start off, whether this fatty liver related or not. And then you do one after that and monitor. And if it's continue to go up, then obviously you have to stop the statin, make a referral. If it improves, then I think it's very safe to continue statins. So again, I think to me, 3 times upper limit of normal is the threshold that I will consider stopping.
Sure. Last question. I mean, this is for myself. But so basically, if a patient has got abnormal liver function tests and ultrasound shows fatty liver, and somebody calculates the NFALD score, and when would be the threshold before a doctor in a primary setting would order a fibroscan or MR elastography?
Yeah.
Is there a threshold for that?
Yes.
Furthermore,
Yes.
or should it be actually part of the whole investigations as long as your liver function test is abnormal and you got fatty liver?
Yeah, so again, thanks for the great questions. Now, I think there are really so many fatty liver patients out there, and we can't order MRE, even though it's one of the best tests non-invasively to determine fibrosis or even fibroscan for them. So I think out in the community settings, if let's say the NAFLD fibrosis score is low, and the online calculator will tell you that patient is low risk, which is F0 to F2, that group of patient you can safely assume that they do not have liver fibrosis, because that test has a very good negative predictive value. But if the result comes back as indeterminate or positive or suggestive of advanced fibrosis, you will need to get a fibroscan or a MR elastography done, because the MR elastography or fibroscan has better sensitivity and positive predictive value for advanced fibrosis than the non-invasive test. Non-invasive test is, I think, attractive because you already have the blood test numbers that you can input in the calculator, which are basically your platelet count, AST, ALT, albumin, patient's age, and whether they're diabetes or not. So simple to use bedside tool that you can adopt. But ultimately, I think if patient want to have a full assessment, then I would still say that fibroscan, MRE are still the non-invasive test that we should go for.
Sure. One last question which just came in before we move on to Dr. Lai. Po Seng, the last question is, can statin-induced transaminitis be reduced with vitamin D supplementation?
Okay, so good question. I am not aware of any data with regards to this. So now, vitamin D itself, as you know, if it's deficient, can cause abnormal ALP, but I'm not aware that it can cause AST, ALT elevation. I'm not sure that it can ameliorate the effect of statin-induced hepatitis. Yeah.
All right. Thank you very much, Po Sing. Now, Dr. Lai, thank you for that wonderful talk. I think a lot of us are actually all fairly familiar with, at least have heard of Boehler's, Bolito's, modified Montgomery, and the very index case which has happened in Singapore, which is the Hitchcock case. But for the benefit of our GP colleagues, are there any index GP cases, at least locally, which have happened, which we can draw reference from, or even experience from, with regards to these three recommendations?
Thanks for the question. Actually, I'm not aware of any case that occurred in the community practice or GP or family medicine practice that has gone that high up into the the courts. So a short answer is no. But in terms of practice, I think the patients are getting more educated. They're demanding a lot more things. So obviously we always say in family practice, in community practice, medicine and community medicine, the stakes are maybe lower because most of the time the general practitioners tend to refer once they send something that's more complicated. And so most of the time the cases get referred to the next level of care, whether in the hospital, and specialist outpatient clinics. And therefore, I'm not aware of any specific cases that involve GPs in particular. However, it's still good practice to advise patients carefully. Like I mentioned, know your patient, know your trade, and know yourself. And really, if you and I think many of our family practitioners have a very good relationship with the patients, and I think that amount of trust, and if you know your patient well, you can always mitigate a lot of all these risks in medical litigation. Thanks.
Thanks, Siang Ping. Well, I do agree that our GP colleagues have got the benefit of seeing a patient for much longer time, and there probably is a lot more rapport than a specialist. Seeing a specialist for the first time and the specialist recommending operation or intervention, that there's certainly a less a barrier in terms of familiarity in that sense. However, I'm not sure whether our GP colleagues they do have to trust a lot more on the clinical acumen than rely on tests. I think that's one potential barrier in which can hinder the assessment of the patient. And so while I do not know of any major cases which happen in the community, but however, a few common scenarios: the red eye, fever, a child with fever, or even abdominal pain. These are the clinical scenarios which a GP will probably not be in the front, being in the front line. They might be seeing it at the first presentation. So I suppose that as a note, how can a GP mitigate this risk in these tricky scenarios, which is a lot more common to them than to us?
Well, I mean, for general practice and family medicine, right? I think most of the time, you know what we always say, we tell the patients, if you don't get better, go to A&E quickly, especially if something is more sensitive like the eye. When you're dealing with the eye vision, anything that is, subtle, kids, pediatric cases with very vague symptoms, or I think it's always advisable to tell the patients if anything doesn't. Of course, in family practice, and I think all of us have this benefit of watch and wait. But then again, you see, most patients probably want something done quickly anyway. So if you advise the patient, if it doesn't get better, if it continues to get worse, please go to the emergency department quickly. Or in the meantime, I see you tomorrow if it doesn't, and I'll refer you to my colleague as soon as possible. I think that rapport that you build up with the patient is probably going to be the best avenue for your action, your plan of action, and how you can mitigate all the risks that we anticipate.
Thank you, Siang Ping. I recently read an amendment to the modified Montgomery, and they divided patients into the normal, the eccentric, and the shy eccentric. So in the context of again patient presentations, would it be useful to actually divide patients up into these three categories?
I
on a practical basis?
I have my doubts about. I mean, the report has gone out, the recommendations have gone out, and there's apparently Ministry of Health and SMC have agreed to adopt all of them.
Yeah.
So we are in the process of trying to make it work. And it's basically, to cut a long story short, it's supposed to be a reversal of the modified Montgomery test to bring it back to a more patient-centric kind of Bolen-Bolito test. And therefore, it's like, how do we categorize patients? Can we anticipate what the patients will ask, or what is this an at-risk patient? Is this a not so easy to handle patient? I think sometimes it's very difficult, right? We don't know. The cases that come and bite are the cases that sometimes are the cases that you least expect sometimes. So I think the guidelines are good, but eventually I think let's put a reductionistic approach to things. If we treat patients as a fellow human being and we do our best, most of the time patients are forgiving. They are only upset sometimes when things don't go right, and they have they have a grievance against the doctor. So like the case of Hitchcock, everything was documented well, and the doctors and the hospital treated him well, but I thought he was quite vengeful in a sense, you see. So he continued to appeal, and the reasons he brought up for appeal were getting more and more absurd, really. So I think in that case it was traumatic for the surgeon, obviously, for the medical team, surgical team. But really, in the end, it does prove that if you treat your patients with the due respect and with due consideration, proper documentation, I think that's probably your best defense. Because you just don't know whether a patient is eccentric or not eccentric, and whether he will turn around after a while and decide to sue. I think that's all I can say.
Thank you, Xiang Ping. Last question. I think it's fairly related to what I've just said. The question, I'll read it verbatim, is: instead of allowing medical litigation to be left to the judges, common law and judge-made law, will it be better to codify the law via parliamentary acts instead? This will restrict judges to mere interpretation of parliamentary intent instead of setting new guidelines on medical practice. I think fairly complicated, but I think
I'll try.
Answer, yeah.
I think first of all, the act, the SMC is a self-professional and self-regulatory body, as we understand it to be. So the medical profession, even, and then the legal profession are some of the so-called professional professions that have self-regulation. And the self-regulation is actually in the form of the Medical Registration Act. And the Medical Registration Act provides everything that is required in the sense of setting up the SMC, and guides the running of the disciplinary proceedings as well. Of course, it is eventually, and therefore any act has to be passed in Parliament, right, in the first place. So if we want to change the law, so to speak, it has to go through Parliament. It has to go through debate. And then what happens is that once it's enacted, the judicial arm, which is the judges, right, the Attorney General chambers or the justice system, will take over and interpret it. So in that case, yes, that's how some of these things called common case law becomes evolved out of it. So to answer that question, I think it is debated in Parliament. The Parliament does have a decision, has a role to play in this, and then the judges are just there to try and interpret it. Now, I think back to the self-regulatory portion. Now, if the SMC, and again, of course, we have our own reservations or comments about how SMC is run or things like that, but without going into that in detail, I think more importantly is that the basis is if doctors and colleagues as a whole in the profession regulates itself well, watches out for one another well, and maintains that level of professionalism, then we don't really need to let the judges tell us what to do, put it that way. It's difficult, but I guess that's the idealistic way of looking at things. I think the doctors should come together and work together and basically minimize the risk of letting what was mentioned, letting the judges establish common case law and telling us what to do, I suppose. So I think maybe I should just stop there. Thanks a lot.
Yeah, that was quite a complicated question to start off with. Do we have time for one last question? No, I suppose not. I just have to reject this last question. I'm so sorry. Well, thank you, Dr. Tan and Dr. Lai, for giving us valuable insights, albeit given our short time we have. And thank you once and all for attending our medical seminar, the Mount E Hospital Annual Medical Seminar. And we look forward to receiving you guys, everyone, again this coming Saturday, where we have a fourth and last session of this year's medical seminar. Thank you very much.
Thank you, Dr. Fu, Dr. Lai, and Dr. Tan for the highly engaging interactive segment. And this is a panel discussion. And this ends our third edition of the Mount Elizabeth Hospital's Annual Medical Seminar Lunchtime Webinar 2020. And of course, we still have one and last final session this coming Saturday at 1 p.m. Now, before you go, we just want to remind you, should you have patients to refer to us or simply wants to make an appointment with Mount Elizabeth Hospital or Mount Elizabeth Novena Hospital, please kindly contact our hotline or WhatsApp number. Please also submit your feedback via this link. You can scan the QR code or type in this bit.ly link that is case sensitive. And finally, we look forward to seeing you for our final installation this coming Saturday on 19 December, 1 p.m. And we will feature these topics presented by urologist Dr. Ronnie Tan, Dr. Tan Yong Kan, orthopedic surgeon Dr. Alan Chong, and we will have a panel Q&A discussion moderated by Dr. Tan Ye Hong, urologist. And today's session will also be uploaded on the event website for all of you to view on demand right after the event. The video for the previous sessions are also available. Finally, we'd like to thank our sponsors once again for supporting us in this event. Platinum sponsors, Teleflex and Pfizer. Gold sponsor, Sandoz. Silver sponsor, Boehringer Ingelheim. Thank you, and we'll see you this coming Saturday at 1 p.m. Goodbye.